as Dr. Glee mentioned, I'm going to talk about the role of local therapy in metastatic prostate cancer. A little bit of the earlier stuff is kind of tailored to some of the residents and fellows specific to kind of the concepts. I know that not everybody does prostate cancer, so I wanted to talk a little bit about where this idea developed from, and then I'll discuss a phase 2 study that we did at MD Anderson, which was 119 patients randomized, followed by the current status of the randomized studies in this space, and where there's still remaining questions. These are my disclosures, not really relevant to today's discussion. The agenda, which we'll skip over here. So when we talk about local therapy in metastatic prostate cancer, we have to understand what the impacts of the treatments that we're applying to these patients are. And to do that, a lot of it needs to or requires randomized trials. If you look at single-arm studies, we often tend to take the best patients with the best prognostic factors, do treatments, and then claim victory when we have a positive outcome. So when we think about this space, we have to first understand what is metastatic prostate cancer and what's the localized space look like. On the left here in the yellow, you have the castration-naive patients who kind of come in the presumed localized setting. You can also see clinically node positive patients, as well as now PSMA PET positive patients undergoing local therapy. Some of those patients are cured by our radiation and surgical treatments, and now some perhaps from focal therapy. We do have a fairly high recurrence rate after these treatments, PSA or clinical recurrence. Some of those can be salvaged. But many of these patients go on to receive systemic therapy when we think that they're in an incurable situation, and then they develop castrate-resistant disease, which is kind of an induced phenomenon by what we do by giving them systemic treatment. Most of what we're talking about today is kind of looking at this de novo metastatic population and seeing if we can take any of these patients who we think are no longer curable and actually provide an intervention, perhaps give them a cure, which has the 3 question marks, because I think that's a big ask, but maybe prolong survival and perhaps delay time to systemic therapy or even decrease the potential for local complications. I put this up because often people think that what I'm referring to largely is oligometastatic prostate cancer, which, by any definition just means low volume of metastatic disease. There's a number of varying definitions on how people would call something low volume or oligometastatic. You have multiple scenarios, but the main ones we're focusing on here are patients who've had an uncontrolled primary, so the red prostate there with maybe a couple small metastatic deposits. We do obviously see oligometastatic populations with the controlled primary where their recurrence are metastatic, and those are the patients that have gone on to things like the Oriole study, the STOMP study, the Extend study, which is looking at trying to treat the metastatic sites and see if there can be improvement in outcome. But really, oligometastatic disease is largely just based on our ability to image these patients. And so this is a nice representation of a single patient at a single time point evaluated with bone scans showing a couple of small bony deposits, a sodium fluoride PET showing all those black spots being more metastatic sites, and then a PSMA PET scan showing that this patient clearly has diffuse metastatic disease. Now, do those sites behave differently? Are there different biologic outcomes for molecular imaging metastatic sites versus bone scan metastatic sites? Still unknown. But the point is that we can chase down all of these things that we can see. If we have better imaging, we're always going to see more. And we know that with PET scan imaging. This is the study that we did. It was a national study called the Lighthouse Study with Blue Earth Diagnostics, showing that PSMA PET scans, when used for patients with negative conventional imaging and planning to undergo a prostatectomy with high-risk disease, had about 10% of patients had pelvic nodal disease that was identified on PET imaging, and metastatic disease in about 20% of patients. So that population that we traditionally thought were localized to the prostate, clearly those patients have a high recurrence rate, up to 50% in 5 years after an operation by PSA measures. Those patients, a good portion of those had metastatic disease at presentation that we just couldn't identify. Now we're identifying some of it, still not all of it. The sensitivity of PET scans are still quite low. And so how do we define these patients? Are these patients now oligometastatic? Are these patients that are patients no longer deemed curable? Should we not be doing surgery in this population? And should this be going on to systemic treatment? For the radiation oncologists on or in the room, they would say all these patients should have radiation. But these are questions that are real questions that have come up, and we're trying to address them with some of the work we're doing. So again, for the trainees in the room, a lot of the times you might hear people talk about something called the Will Rogers phenomenon, and that's essentially where a change in something shifts and makes things better in both groups. This is just a visual illustration of that, so you can understand what that actually means in the setting of high risk and metastatic prostate cancer. So if you look kind of at the historic published data on metastatic prostate cancer, there's about a 90% 10-year survival for patients undergoing local therapy. So these patients may have to have the morbidity of our treatments for a long time before they actually succumb to their disease. In metastatic population, about 50% 5 years. And again, this is most on historic numbers. Now with PET scan imaging, we're shifting the bar. We're seeing metastatic disease that we were not seeing before. So the patients who have high-risk localized disease now have an improvement in their survival. And the patients who have metastatic disease also see an improvement in their survival because now you're including better prognostic patients in that group. Stage is prognostic. This gets to some of the points I was making earlier related to picking patients and then treating them and then saying that we did them a favor by doing so. We know that patients with M1A disease do better than patients with M1B. So those who have extrapelvic nodal mets do better than patients who have bony mets, better than the combination of the two, and better than patients with visceral mets. And even visceral mets, there's some discrepancy on whether it's liver mets or lung mets. Lung met patients tend to do quite a bit better. But it's important to understand this because these are clear things that we have to think about and risk stratify for when we're putting together clinical trials. And this is a busy slide, but I'm going to highlight the things of importance. This is from the Stampede data, from the charted data. And the point of this is to show you that in the high volume de novo metastatic population, the median overall survival was 48 months. In the low volume, 58 months. So automatically a 10-month difference in the population and the outcome of these patients based on the volume of their metastatic disease. However, in those that have had local therapy and then develop either high volume or low volume metastatic disease, not much of a difference. But both of those groups do metastatic. So de novo metastatic already has a poor prognostic, is already a poor prognostic indicator for patients that presenting with metastatic disease. And then finally, PSA response at 7 months. This is true in the ADT era. This is from Maha Hussein's paper from JCO in 2006, looking at after a period of induction of ADT for patients with metastatic prostate cancer, what was the PSA and then how did those patients do? And if your PSA went undetectable, those patients had a median survival of 75 months. If your PSA was 0.2 to 4, it was 44 months. And if it was greater than 4, it was 13 months. So PSA, for all of the faults of PSA in the screening world, it's great from a monitoring for treatment, monitoring for responses, and it might actually be something we should be thinking about and using for risk stratification after a period of induction therapy. So when someone has metastatic disease, I think you've all heard the phrase "the cat's out of the bag" or "the horse is out of the barn." Depending on where I am, I use a different picture. For some reason, I associate cats with Canada, and I don't know why that is, other than my boss is Canadian and he's got a lot of cats in his house. And so the cat's out of the bag, and really, is there any point to treating the prostate cancer that still remains in the primary tumor? Or are we able to use surgery and radiation as the superheroes coming in to kind of help improve the situation for these patients? So what's the rationale behind this concept, and where does it actually have supporting data, and what can we do with that information? So for the trainees, we talked a little bit yesterday about a career in academic urology and how to find fulfillment, and what are the things that you actually want to lean into as you come across them. And this was one for me. I actually went to MD Anderson with the intent of being a kidney cancer doctor. Saw the light in about 2011. But I worked with Chris Wood, who was my mentor and friend, and spent a lot of time in his lab in my first year. He did a lot of work looking at cytoreductive nephrectomy, doing treatment in the locally advanced kidney cancer space. And in our multidisciplinary meetings that we had each week, we would always talk about these patients with low volume metastatic prostate cancer. Should we treat them? They're going to have symptoms. People would all have all these projections of what was going to happen, but nobody seemed to have any data to support that. So in 2011, my co-fellow Scott Delacroix and Anna Aparicio sat down and we said, we should actually study this. We should try to figure out a way to look at this and see if it makes sense so we can actually put some data behind it. We all think it makes sense, but does it actually make sense? And so we put together a question of, does treatment of the primary improve outcomes in metastatic prostate cancer? And so what would be the question surrounding this? We look at, does treatment improve things like progression-free and overall survival? Symptoms and adverse events came up quite a bit, and that's something that I'll talk about a bit with the actual studies that have been published to date. The likelihood of local symptoms, I think for all of the trainees, especially the ones that are kind of running down to the ER to deal with all of the patients with gross hematuria and obstruction, feels like every patient has a problem. The reality is it's actually probably a bit less than what you think, because there's a lot of patients that do well and never see you. The timing of the intervention. So what we're talking about here is newly diagnosed metastatic prostate cancer. There is a question of, can we identify patients that may benefit most who actually first develop early castrate-resistant disease? Does the location of the progression event, whether it's the primary or the metastatic sites, impact the decision to move forward with treatment? Is it just better to wait till patients become symptomatic and provide palliative treatment? Palliative cystoprostatectomies, palliative exonerations do happen. I'm sure they happen here as well. They're not too frequent, but they do happen. And we do see improvement in the patients suffering from those issues. The question is, can we do that earlier at a time point when it's less likely to cause long-term problems and an easier operation for the patient and a better quality of life? And then finally, the question of that, as we get better systemic therapies, do we actually lose the potential benefit that we think we are providing to the patient with the local treatment? And the better systemic therapies actually dilutes that potential benefit, and those patients no longer will need local treatment. So many of you may be familiar with some of these studies. These are basically looking at SEER, the NCDB, and the Munich Cancer Registry, trying to identify patients with metastatic prostate cancer who had subsequent local therapy, and then compare those to the patients that had systemic therapy alone. Now, we all know that when you use large population-based data, there's inherent selection bias that comes into play. Many of these patients were selected because they were the better prognostic patients, had the better response to the PSA with the induction of hormone deprivation therapy, were younger, fitter patients, and so there's an issue when you compare, but the separation of these curves are fairly dramatic. And so this raises that question. A lot of these papers were being worked on. Stephen Culp was a former fellow at MD Anderson, was working on this when I was at MD Anderson. Russ Tovin was a collaborative effect. I was involved with that paper that was published in JCO in 2016. But all of these ideas were coming to fruition, at least to show some supporting data. This data is hypothesis generating. It says to us, maybe we should investigate this. It's not something we should apply to our daily practice. So the symptomatic question, when you look at patients who've had prior local therapy and then develop metastatic disease, have castrate-resistant disease, and then if you list the things that we see, ureteral obstruction, hematuria, urinary retention, pelvic pain, how often do those things happen in the CRPC setting later on in the patient's life? After surgery, we still see it in about 20% according to this study, 47% after radiation, and in 54% of patients who didn't have any prior local therapy. So a 54 to 20% reduction may be reasonable if we can select the patients out that might be in that group that are at risk for having a symptomatic event. In a population of patients presenting with de novo metastatic prostate cancer, again, remember those patients have a worse prognosis. They also tend to have more symptomatic presentation. So about 65% had symptoms in the study when they presented with their metastatic disease. These are some of those symptoms listed below. These are real things and real problems. Some of them maybe not as extreme as the others. And so the reality is what we'd like to do is decrease the need for possible interventions if we're going to use symptomatic progression as an endpoint of these studies. Timing, I put this up. This is one of three studies that came out of MD Anderson. This one was looking at prostatectomy in the setting of castrate-resistant disease, so patients who have progressive primary tumors. This was on a series of 3 clinical trials where patients needed to have tissue excised in order to go on to an IO-based therapy study. We put those together to look specifically at whether or not there was a high complication rate of operating on patients who had received systemic therapy for several months to years prior. And also showed that there was really not any significant change in their epic urinary scores. But again, the timing comes up. So if you wait until you can identify the patients that might declare themselves as likely to be symptomatic, perhaps we're only providing treatment to a small portion of the population that have metastatic disease. And then finally, before moving on to some more data, this is an example of, I think, what we often saw back in 2011 when I was in my multidisciplinary meetings. You would have a 52-year-old, PSA at 21, Gleason 9, had a bone met to the ischial bone. And we would take those patients and give them treatment and then say we should probably do something to their primary without any evidence to support that other than what I've already showed you. This is an example of a patient who we enrolled on our early phase 2 trial where they received hormone therapy. PSA went undetectable after the 6-month period and had a prostatectomy a couple months after that and went out to at least 60 months with an undetectable PSA. So some might look at this and say, all right, we did a good job. We can declare victory. But the reality is would that patient have done well despite us? And that's an exact situation with this patient who received the same course of therapy, except it was not randomized to the local treatment, was randomized to the systemic therapy alone. So you have these kind of significant hormone therapy responsive tumors. This patient went 68 months with an undetectable PSA with no intervention. So this is the necessary part of a randomized trial, is that when you're comparing these, they are no different. So did the intervention actually provide improvement? And I'll show you some of that data. This might be the first time that I present that publicly. It's not published yet, but it's in submission. So correlation does not equal causation. We've heard this over and over again. The need for randomized trials allows us to actually compare things effectively and evaluate the scenario. So potential mechanisms, there's a lot of conceptual things and hypothetical things and theoretical things. There's not a lot of data to support this clearly. But if we look at patients who receive hormone deprivation therapy, can have significant responses. This example here is a patient who had essentially his prostate replaced with tumor. He received ADT alone. PSA went undetectable, was on our trial, had a prostatectomy, had residual viable disease in up to 70% of his gland, with findings of intraductal spread, which we know is a poor prognostic factor in patients with localized disease. In this trial, we basically looked at patients who received a year of chemohormonal therapy, including docetaxel, gave those patients a year of systemic treatment, had a prostatectomy, and after the prostatectomy, when we looked at compared the untreated versus the treated patients, we saw an upregulation of a lot of the pathways that are associated with EMT, and we know are at least preclinically associated with lethality in prostate cancer. So these tumors get treatment, but they never actually go away. They just become more angry and eventually become resistant to our therapies. So tumor debulking, we talked about local progression, but there's all of these conceptual ideas around changing tumor biology. Can we reduce the number of shed metastatic cells by removing the primary? Does the primary shed these cells in waves, or do they actually have a one-time event where all of these cancer cells are spread out throughout the body, and then some of those will develop further, where metastases then metastasize even further? Is there an immunosuppressive event that's occurring? Is there a paraneoplastic or even a hormonal interaction with autocrine or paracrine secretion from the primary tumor, or an interaction between the primary and the metastatic sites? All things that need to be evaluated further. There are a number of considerations against local therapy, and I wouldn't be fair to just talk about all the things about where the mites might be, where we can help patients, but we should also look at where the things may not be helpful. I mentioned already, if we had better systemic therapy, perhaps this wouldn't be necessary or even a consideration. There is morbidity of our local treatments. We know that patients have risks of urinary leakage or incontinence. We know that there's an impact on sexual function, which for many of these younger men actually is a consideration, even in the setting of metastatic disease, because they can still have erectile function, which is important for their relationships. When we look at, again, this concept of we see a young, fit patient and we want to do as much as we can, doing more doesn't always mean that we're doing better for them, and we have to be aware of that. And then palliation at the time of need for palliation, as opposed to trying to do these pre-palliation approaches, may be better and may limit the number of patients who receive treatment.
So the first line there presumes that if you have better systemic therapy, the need for local control reduces, but that's not necessarily true in other tumor paradigms, most notably testis cancer, where better systemic therapy is the opposite. It speaks to integration with multimodals to optimize
I agree,
outcome.
although what you're treating often in a testicular cancer scenario is the tumor that's not responsive to the systemic therapy, right? Currently. And I think that the point would be just that if we had therapy that was actually cytotoxic and not just suppressive, would we actually need to be doing this in its consideration? Or would it be like Testis where we actually see which ones have residual tumor in those scenarios, and those are the ones that would actually have an application of treatment? This is just an example of a study that kind of speaks in opposition to the concept of cytoreductive prostatectomy. This is from a German study where one site they did cytoreductive prostatectomies on all patients who presented with metastatic prostate cancer. The other site, best systemic therapy alone. When they compared the two patients, again, 83 patients, not a huge study, but no difference in progression-free or overall survival in those patient populations. So just some evidence to suggest maybe this isn't the right thing, which is why we need to actually look at this in a prospective fashion. And then finally, before hitting on the trials, I want to talk a little bit about biologic heterogeneity. Some of the work that we're doing in the castrate-resistant space that has actually been applied to this population. And the reason that we initially did our phase 2 study as we designed it, which I'll show you here in a minute. So this gets a little bit to, I think, what Dr. Glee just mentioned, is that, we have these biologically distinct subsets of prostate cancer, and they may have unique therapeutic vulnerabilities. They may be identifying patients who can benefit most from certain systemic therapies based on what they inherently have within them. Or they may be situations where those are more unresponsive to systemic treatment, where local therapies or metastasis-directed therapies may come into place. A lot of work that we've done at our institutions looking at specifically the androgen-driven or highly androgen-dependent population, the androgen-indifferent population, which has been termed the aggressive variant prostate cancer by our medical oncology team, looking at patients who have P53, RB, and PTEN mutations. Any combination of the two, those patients tend to behave differently, both clinically and biologically. And then obviously there's going to be a gray zone in the middle, which is which direction are patients headed, and is the direction often influenced by our systemic therapy and kind of an induced phenomenon or under the selection pressure of the treatments we provide. This is the original publication from Anna Aparicio looking at a number of clinical features, one of them being specifically if the patients had a bulky primary tumor present. There was other associated things like small cell, neuroendocrine features, poor response to systemic therapy, low PSA producers in relationship to the volume of disease throughout the body. But the one that actually came back to be one of the strongest predictors prognostic factors for survival and progression-free survival was having a bulky primary tumor in place at presentation. So they went back through and identified that having those combination of tumor suppressors categorized these patients. And then from there, they did a study looking at, in the castrate-resistant population, the use of cabazitaxel versus cabazitaxel and carboplatin. Remember, this is a CRPC population, which is why we have kind of that steep drop in the progression events for these patients. This is survival. And you can see that those curves split with a hazard ratio of 0.69. So the patients receiving platinum-based therapy had a better outcome than the patients that did not receive platinum-based therapy in the CRPC setting. When they went back and looked at the AVPC molecular signature, they found that if you had the combination of at least two of these tumor suppressors, that those patients actually are the ones that benefited most from the addition of platinum-based therapy. So this is moving towards the concept that this may be a predictive marker where those patients who have the AVPC molecular signature should be receiving platinum therapy to have an improved outcome, where the ones that didn't have it may not actually receive benefit from platinum. So this was a randomized phase 2 that they completed and published in Lancet Oncology in 2019. And that led to the SWOG study, which is now open and active for patients with metastatic castrate-resistant disease undergoing evaluation for the AVPC signature. They're stratified by that, but they're not actually put into categories by that, which is how you would actually want to perform a study to determine if a biomarker was actually predictive for outcome. And so then those patients received cabazitaxel or cabazitaxel and carboplatin, looking at radiographic progression-free survival as the primary endpoint, as well as a number of other endpoints of interest. So this is, again, looking at that population of AVPC, are we able to provide a predictive marker for patients that should be receiving platinum-based therapy? Now, why am I talking about this in the setting of a de novo population of patients who have metastatic prostate cancer and trying to identify who may benefit from local treatment? Well, we took a number of our patients that had de novo metastatic disease, and we took a number of samples from those patients, including blood, to look at circulating DNA, and then also the pre-treatment, so treatment-naive biopsies, so patients who had received no therapy presenting with de novo metastatic had a prostate biopsy, performed whole exome sequencing on these, just did a handful to try to develop some pilot data, and found that the patients who had progression, early progressive events, tend to have a higher number of somatic mutations present. And the patients who had the AVPC signatures, so the RB, P10, and P53 combinations, were more likely to be in that early progressor group. So with that information, we were able to get a PCF Challenge Award to look at this in our phase 2 study, which we just completed the phase 2 clinical data, and we have some of the data to share on at least the molecular signature. The circulating data is not available yet. But many people thought that the aggressive variant prostate cancer signature, so the combination P53, P10, or RB loss, would be a result of the selection pressure of systemic treatment. So you give patients hormones, you give patients chemo, you give patients ARPIs, and now you're forcing those cells that are no longer responsive to develop, and you develop this AVPC molecular finding. But when we looked at it in the de novo population, so untreated, no selection pressure, we actually saw that about a third of the patients, and this is a small sample of evaluable patients from the study, but about a third of the patients, at least, that were evaluable, actually had the aggressive variant prostate cancer signature early and upfront. There's actually now studies looking at carboplatin-based therapy in patients who have the AVPC signature in the de novo population to see if those patients might benefit from platinum-based therapy early and upfront as well. If that CRPC study has a positive outcome, I think we might see that moving up further in the disease space. And I've talked to Dr. Khalib about doing this perhaps in the GUN study in patients who have those findings present, and we have the possibility of adding that arm on at a later time. So when we look at this is from our phase 2, 120 patients. Of the patients that were evaluable for the signature, it looks like about 70 patients here, meaning that some of the patients just had such a significant response to the therapy that you actually couldn't delineate whether or not they had these findings. But you can see here for progression-free survival and overall survival, comparing the AVPC present or not, you do see a separation, and you do see worse outcomes in those who are AVPC positive. Clearly, on the left, you see a significant number, but you do see separation here. The numbers are small, so it's not powered to show that difference currently, but essentially we're seeing at least the trend towards a separation of these based on the AVPC findings. All right, I'm going to spend the last 15 or 20 minutes talking specifically about the prospective clinical trials in this space, including the ones that we've worked on. Many of you are familiar with the HORAD, STAMPEDE, and PEACE-1 trials. These are trials in the metastatic de novo population looking at hormone or systemic treatment with or without radiation to the primary. HORAD was ADT alone. STAMPEDE was ADT with about 16% of patients receiving docetaxel chemotherapy in addition. PEACE-1 was looking at standard of care, which at the time was defined as ADT docetaxel with or without the use of abiraterone therapy. And then they also looked in all 4 of those arms with or without the use of radiation therapy. All of these have been completed. As a reminder, the overall survival outcomes for the entire cohort for HORAD and STAMPEDE were both negative, so radiation didn't impart a survival benefit in the entire cohort. When you look at the STAMPEDE study in the low volume subset, those who had 5 or less bone mets, there was a separation of the curve. On the left was the original publication showing an improvement in survival in those who received radiotherapy to the primary. The longer prolonged follow-up on the right with a hazard ratio of 0.64, showing that patients with low volume disease had a survival advantage if they received radiation to the primary tumor. Now, we don't really have a lot of this data in the low volume subset of prostate cancer patients with metastatic disease with surgery. There is a study that came out of China in 2022 that was published in European Urology Oncology, looking at about 200 patients. 96 received radical local therapy. The majority of those, 85, received surgery. these patients were low volume and that they had M1A or less than or equal to 5 bone mets or M1B. About 48-month follow-up, these patients did receive ADT alone, and you do see separation for radiographic progression-free survival as well as overall survival, with an advantage in the patients receiving surgery to their primary. Now, the challenge with both of those studies, in my mind, is that those studies were done in the era of conventional imaging. So these patients largely had bone scans, CT scans, perhaps a plus or minus MRI to the pelvis. And when you look at these patients who have single 1-2 bone mets on bone scan, how often are those actually metastatic disease? This was a nice study done by Thomas Hope where they looked at patients who had bone scan positive or bone scan and PET scans, bone scans that were positive. When they were actually tried to confirm that on PET scans, less than half of those patients actually had confirmed metastatic disease by PSMA PET. And we see this, and I'm sure you see this, where patients come in, they've been told that they have metastatic disease to a bone lesion. It's never been biopsied. They've been given systemic therapy. Repeat imaging shows no difference. You treat the primary, and they're cured because they were called inappropriately metastatic at presentation. So the question is, how many of those patients actually received benefit and survival because they had local therapy to a curable tumor versus actually metastatic disease? So piece one gets to the question of, if we enhance our systemic therapy, do we still see the benefit in the patients with radiation to the primary? This patient, as a reminder, is standard of care. So ADT, docetaxel, plus or minus abiraterone therapy, plus or minus radiation therapy. When we look at the low volume subset, we do see that with the addition of radiation for the standard of care arms, no difference in survival outcomes. So patients did not have the benefit of survival with radiation to their primary. Now, there was an improvement in progression-free survival, but again, how we define that alters how we can interpret that information. On the right, this is trying to break it down by all 4 categories where you had standard of care plus or minus AbbVie plus or minus RT. And you can see there's no discernible difference. There are separations there. Largely the separations are in response to the addition of the abiraterone therapy, not the radiation to the primary. Now, when you talk to the radiation oncologist, I talked to Alberto Bossi at ASCO when this was first presented. They presented that patients had less serious GU adverse events if they received radiation to the primary. So whether or not they received abiraterone, the radiation actually decreased the serious genitourinary adverse events in the low volume subset. And this was what was presented at ASCO. And subsequently, I was sent a copy of the slides showing what those events actually were. And it actually ended up in the publication in Lancet. And I want you to take a look at this because this is, I think, the critical component of what we're talking about here. When you look at the patients who received RT versus no RT, really no difference in urinary catheterization, double J stents, nephrostomy placement, those undergoing surgery, probably, presumably for palliative treatment. The big difference was in those patients who received, now lumped together, prostate RT or TURP. When you actually look at this in more detail, the big difference, about 23 patients in the no RT group actually received radiation to the primary. So the thing that you're calling a serious adverse event is the thing that you're applying to all these patients as the intervention. It kind of raises the question of, does that make any sense? So I would say that, right now, if you look at this, you would think that by doing radiation in a low volume subset, you're going to reduce their risk of adverse events. I'm not sure we want to radiate every patient to actually prevent 23 patients from having radiation. So, sorry. So in the surgical space, I mentioned the study that came out of China. That was the one that was published already. There are a number of other phase 2 and phase 2 lead into phase 3 studies that are out there. The MD Anderson one, I'll show you here the results in a moment. GRAMP was discontinued after Stampede RMH came out because they didn't want to treat randomized patients to no local therapy when there was evidence that radiation to the primary improved patient survival. So that study was ceased, although I think they had enrolled about half of the patients, which is around 130, 140 patients, and that publication should be coming out shortly. And then trombone, which was M1B patients, ADT with or without radical prostatectomy, was mostly a pilot or feasibility study just to see if patients would be amenable to randomization, which is a challenging part of these types of trials. And then there was a phase 2 study by Isaac Kim called SimCap, which was looking at that low volume subset randomized to local therapy with radical prostatectomy or not. The plan was to do the phase 2, do an interim analysis if there was no clear benefit to the patients at that time point, then not to continue on to a phase 3. But if they did see separation, they would do the phase 3. That phase 2 has finished and completed, and they will not be pursuing phase 3. So back to how we originally designed our phase 2 study and the reasoning behind it. When I said that people were looking at this concept in a non-trial fashion, they were looking at the oligometastatic population, they were looking at those with PSA nadirs less than 0.2, so those who had good responses to the initial induction treatment. And those are the patients that people thought would benefit most from local therapy. But we actually weren't sure. We said, well, maybe that doesn't make sense. Those people might actually respond really well to hormones, so why do we want to do local therapy in them? Maybe the ones that actually benefit most are the ones that do worse and don't have an improvement. So we, instead of having a biased approach to our initial evaluation, we did have an unbiased approach. We allowed patients with multiple or polymetastatic disease. We allowed patients with visceral metastasis. The ones that made it to the trial were largely lung metastasis and not liver metastasis. But they had to respond to systemic therapy for 6 months and show no evidence of progression. So we did a phase 2 study, which was randomized to local therapy, could be choice of radiation or surgery with the addition of best systemic therapy. The majority of these patients received ADT because it started in about 2013. And then subsequent to that, we did have patients receiving chemotherapy after the CHARTA data came out. They were stratified by whether or not they received chemo, and then followed until castrate-resistant progression. We did see a fair number of patients, I'll show you those numbers in a second, who actually progressed within the first 6 months. But what that allowed us to do by including them in the study initially was that we could take prostate biopsies, blood, and do imaging at all these time points, and then actually look at those to see if we could identify prognostic or even potentially predictive markers, or at least set ourselves up for the phase 3 to do predictive markers. So this is a bit small, but we evaluated enrolled 180 patients into the study. We had about 26 that progressed in the first 6 months, so about 15%, which is a little bit higher than I think people would anticipate. Most we expect are going to respond to systemic treatment with hormones. A number of patients declined randomization, which kind of gave us some insight into whether patients would be open to be randomized to local therapy or not. And then ultimately, 119 patients total came through the study. When we looked at just overall population, the entire cohort as high volume or low volume metastatic disease, we did see separation of the curves. So this population is consistent with all of the published data out there showing that these patients do have a separation based on the volume of their disease. We saw very little toxicity, at least no 4 and 5s. The grade 3s were largely patients who had to have drains placed after an operation due to lymphoceles, so temporary grade 3s that resolved. A number of grade 1 or 2s, but similar to what you see in the local therapy population. The EPIC data is vast and being evaluated, but I don't have any of that to share. But unfortunately, when we look at the outcomes of these patients, we saw no difference in progression-free survival or overall survival with the addition of local therapy to the primary tumor. Now, again, this is an unselected population. We did that intentionally at first because we weren't sure if the low volume or the high volume were going to benefit. This study started before those publications that came out with the low volume data. And when we looked at this, we didn't have the data at that time. We didn't have enough follow-up at that time to really figure out whether or not there was an impact of the local treatment. So we moved on to a phase 3 before we actually had this data. Now with the phase 3, this is the SWOG study that, so it's largely North America. We do have some South American sites now, but taking patients with de novo metastatic disease, standard systemic therapy per any NCCN guideline recommendation, which allows for changing therapy over time, and we've seen changes over time. Patients are then stratified by a number of factors and randomized to systemic therapy with or without definitive treatment. Again, radiation or surgery are both allowed. We've enrolled about almost 800 patients of the 1270 that were planned. But we've only randomized about 675, 680. So we have about 400 patients to go in order to complete this study. This looks at progression and then overall survival as endpoints. 660 was as the last time this was updated. And patients for this study, they have to be deemed resectable. So, we kind of avoid the T4 patients who have unresectable primaries. If they have PSMA PET positive, only metastatic disease, and a solitary site, it does require a biopsy confirmation. And metastasis-directed therapy, although not a standard of care, but being used by many, is allowed as long as it's completed prior to randomization. I do think that the question of benefit of local therapy remains, and I think I've shown you there's thoughts in both directions. So the challenge here is knowing that the phase 2 was negative, and now we have a very similar study designed for the phase 3. Completing this study may give us insights into the biology and, again, that biologic heterogeneity that exists, and we have many samples to look at in this population. But given the phase 2 was negative, it's hard to determine whether or not completing the study is going to be beneficial for patients. We were able to receive an R01 grant working with Amir Goldkorn through SWOG. We've taken samples from over 600 patients, 3,500 samples to date. Our R01 is looking specifically at liquid biopsies and radiomics and the combination of the two to see if we can identify, again, prognostic and predictive factors. Ultimately, I'd like to look at that in the setting of whether or not patients receive local therapy to see if we can identify patients that may benefit and why they would benefit, and if we could identify them early and upfront. So basically, I think the goal for this, just like the goal for high-risk localized disease and the goal for many of the cancers that we treat, is to try to provide more personalized care and more personalized approach to patients with metastatic disease or any prostate cancer. Using these things like clinical features, which is what we've been using forever, genetics, genomics, molecular markers, our induced responses to systemic therapies and findings of residual disease, as well as biologic imaging, to then personalize their care and provide them with the most appropriate therapy. For some of the younger folks, this is a Pink Floyd reference, which is what I listen to in the operating room. So I'm going to conclude here. I do think that cytoreductive surgery should not necessarily be offered off of a trial. It's likely not beneficial in everyone. I hope that we've seen that. It seems that there is evidence supporting that it's probably not beneficial in most. But I do think these trials allow us to understand the biology, the mechanisms that we're trying to look at for response to these treatments, and then ultimately intelligently, or at least more intelligently than we're doing now, integrate multimodality therapies and personalized care. So support clinical trials. I know that this group does that, so that's a great thing. A lot of acknowledgments for people that have been involved with this work over the last 15 years, and obviously the patients that enroll in the studies. And I'll finish with when you put an American on a Canadian's bike, you end up with a flat tire. And this is Peter changing my tire yesterday because I popped it on the ride. So thank you very much, and I open it up for questions.